Our topic for tonight is small intestinal bacterial overgrowth and irritable bowel syndrome. I'm going to give a brief intro to the topic and then I'll introduce our guest speaker. Irritable bowel syndrome is the most common gastrointestinal condition. Thank you. We'll see if we can get it back on when we need to. With an estimated prevalence of between 10 and 20% based on population studies. IBS is a condition marked by abdominal pain, gas, bloating, constipation, diarrhea, alternating the two, and urgency. When patients with IBS undergo colonoscopy, there's usually no visual pathology, unlike patients with inflammatory bowel disease, like Crohn's. For many years, IBS was seen as a condition arising primarily from psychological stress, until Dr. Pimentel discovered that an overgrowth of bacteria from the colon into the small intestine was the causative agent in an overwhelming majority of cases. However, this was not easily accepted by the medical profession. And for the most part, it's still not widely accepted. For example, the website for the American Society for Colon and Rectal Surgeons states, no clear answer exists as to what causes IBS. It's believed that the symptoms occur due to abnormal functioning or communication between the nervous system and bowel muscles. Even Cedars-Sinai's website, where Dr. Pimentel and Dr. Rezaie work, states that health experts have not been able to find an exact physical cause for IBS. It is often thought that stress is one cause, quote unquote. Most gastroenterologists, I'm sure you can tell me better, continue to treat IBS with an array of drugs that control the symptoms, including the diarrhea, constipation, pain, etc. But then along came Dr. Pimentel, and he discovered not just the cause of IBS, but he created an entire movement, the world of SIBO, complete with SIBO testing, SIBO supplements, the SIBO Doctor podcast, SIBO conferences, like the integrative SIBO conference in a couple of weeks in Seattle that Dr. Rabar and Dr. Pashtani will be speaking at, who are our last two speakers this year. Tonight our speaker is Dr. Ali Rezaie. He's the medical director of the GI Motility Clinic at Cedars and a close associate of Dr. Pimentel's. Dr. Rezaie will present some of the latest research related to SIBO and IBS and will help us to understand some of the root causes of IBS. And while he's not a functional medicine doctor, in functional medicine we are all about trying to get to the root causes of health conditions.
So thanks for coming, thanks for the invitation, and just let me know if my voice dwindles down and then you can't hear me, just speak up, and feel free to jump in and then make this interactive. So we're going to do this talk mostly on the breath testing, and then and how it's done, when it's done, and what's the pathophysiology of the fact that we do breath testing in small intestinal bacterial overgrowth anyways. And then at the end we're going to have plenty of time to do Q&A. So breath testing is nothing new. And it has been going on for many thousands of years. Hippocrates talked about aroma of human breath that can give you clues to diagnosis of diseases. And Avicenna, that wrote his book in essentially like almost 1,000 years ago. So what he said is that if you see a patient that has sweet urine and also a musty smell of their breath, that patient is going to die very soon unless you hydrate the patient. And so now we know that he was describing DKA, diabetic ketoacidosis. This day and age, thankfully we don't taste the urine to diagnose diabetes. We have better tests, but that just shows these mind-blowing observations that people did more than 1,000 years ago. And funny enough, it's still diagnosed DKA obviously with the urine test as part, and also the main management remains insulin and hydration, what he suggested. So we have been, as scientists, we have been fascinated by breath for a long time. So the fact that breath contains different types of gases as opposed to ambient air goes back to Rezaie, that discovered that, wow, there is oxygen, and also, more importantly, there is CO2 in our exhale gas. The only explanation at that time that we could come up with is that, so probably our lungs are our chimneys, which in fact is actually correct. It's essentially everything burns down and then CO2 comes out, just like the chimney of an engine. So that was another observation that was very impressive, and interesting enough, Rezaie not long after this was decapitated during the French Revolution. But he lived to discover and be the father of modern chemistry. So what is the intestinal gas? How much gas do we have? So the exact number obviously is quite variable in different patients and different individuals. But on average we have about 100 cc's of gas in our bowels. But this varies immensely depending on the size of the patient and also whether the patient has excessive amount of fermentation in their gut or not. So 99% of the gas in our gut is odorless. So hydrogen, methane, carbon dioxide, nitrogen, they're all odorless gases, which is interesting. The smell of the gas and flatulence only comes from less than 1% of the constituents, which is the majority of the part is the hydrogen sulfide that obviously has the smell of the rotten egg smell, and scatol and ammonia. All right. So how do we get rid of the gas? There are multiple ways to get rid of the gas. So belching, obviously, and also flatulence, two obvious ways that we can get rid of the gas in our GI tract. Obviously, there is one other pathway that was recently found in the last half a century, which is via diffusion. So this gas goes into the circulation, diffuses into the circulation, and it goes all the way, passes the liver, passes the first pass, and ends up in the lungs, and then we breathe it out. And in fact, that's actually the basis of doing breath testing as well, and that's how we pick up the gases that are produced by the bacteria in our gut, eventually in our lungs and in our exhaled breath. And we're going to talk about that a little bit more there. And also another fascinating concept is bacterial consumption. There are multiple bacteria, obviously millions of bacteria. I'm not going to talk in detail during this talk about microbiome. There are different bacteria and archaea and fungi sitting in the gut, and they use each other's gases to produce their products. A great example of this is methane-producing archaea, that they use hydrogen produced by hydrogen-producing bacteria to produce methane. Because by ourselves, we do not produce hydrogen.
Let me just interrupt for a second. The archaea are primitive organisms that are found in the gut, like bacteria, and they produce the methane gas, right?
Yes, we'll get there. Correct. So archaea are even older than bacteria in terms of evolution, and they're extremely resistant. You can find them anywhere from the hot spring all the way to Antarctica. Actually, NASA just suggested that if we find life outside of Earth, possibly it would be an archaea. But interesting that it has been around, and they're very resilient, and we're going to get
the aliens are in our gut.
Yeah, there you go. There you go. There's a joke about that. I'll tell you after the talk. All right. So How about the intestinal gas? How is this produced? So it is obviously some of the gas is by the swallowed air, and the gas that is in our food that we eat. Obviously there is some sort of air and different gases is in there, but that's not much. And also the chemical reactions. A classic chemical reaction is the acid in our stomach, if there is bicarbonate in your food, ends up producing carbon dioxide and water. And there are multiple other reactions that can lead to production of gas in the stomach. But the most important gas production in the gut remains the bacterial metabolism, apart from the diffusion of the gases from the bloodstream, which is very small. So what's the hype about hydrogen and methane? The hype about it is that they are exclusively produced in our body by the bacteria and archaea. Our cells are incapable of producing hydrogen and methane. So any hydrogen or methane, whether you find it in the gut or you find it in the exhaled breath, is produced by the bacteria inside the gut. So they are exclusive biomarkers. So in medicine, we don't have many exclusive biomarkers. Nothing is exclusive. But this is one of the few examples that in medicine that we have an exclusive biomarkers. And that's why by understanding how these gases are produced, we can learn a lot about microbiome and also the health of the microbiome in our body. So, go back, wait. So, and how do we know that they're exclusively produced by the gut bacteria? Multiple studies have shown that, for example, germ-free rats. So germ-free rats are these rats that are developed in facilities that are absolutely sterile. There is no bacteria in the gut of these animals. So they do not produce any hydrogen or methane in their breath. And also infants in the first day of life, when they come in, at the beginning they don't produce hydrogen or methane, but as they pass the vaginal canal and they're exposed to a microbiome, and then the microbiome in the gut starts to develop and multiply, then you'll see slowly that the hydrogen and a small amount of methane start to produce in the breath. So this is a very schematic and a very simplified way of understanding the interaction between the bacteria and archaea in our gut. So the most common guys are the ones who produce hydrogen. So hydrogen producing bacteria. But then if you move forward, there are methanogenic archaea as well, that they use the hydrogen produced by hydrogen producing bacteria to produce methane. What else is in there? There are acetogenic bacteria out there that again, they use hydrogen to produce acetone. There are also sulfide reducers and also nitrate reducers as well. So, and more we're learning about all these bacteria in our gut and what exactly they do and what exactly they do when they overgrow in our body. For example, when we're going to get there, if you go back one slide, with the sulfide reducers, we're going to see that you get diarrhea and rectal urgency, as opposed to a methanogenic archaea that majority of the times, if they overgrow, you get a lot of bloating and constipation. But from this schematic view, you can see that hydrogen sulfide producing bacteria and methanogenic archaea essentially compete over hydrogen. So these are competitors. So they do fight with each other inside the gut. And that is important to interpret the breath testing as we move along. So what's important about breath testing? So here's the beauty of GI tract. You know that there is a nuclear amount of bacteria sitting in our mouth, right? 10 to the 9 sometimes per ml of bacteria sitting in the mouth. And then you go to the stomach, all of a sudden less than 100 or even less than 10 bacteria sitting per ml. And mostly because the stomach acid kills the majority of the bacteria, right? But then you move on to the small bowel, less than 1,000 of bacteria you can find per ml in the gut. On a regular basis, about 100 per ml. And then all of a sudden you go to the colon, now we're talking about 10 to the 10. 10 to 11 or even 10 to 12 bacterial microorganisms that you can see. So billions and trillions of bacteria per ml. So this bizarre gradient of bacterial composition in our GI tract is maintained very rigorously in a healthy individual. Mostly, obviously, stomach acid, but the most important thing is the GI motility that helps keeping the small bowel relatively sterile, even though it's surrounded by areas full of bacteria. The big thing that controls that is the migrating motor complexes, which are the housekeeper waves. So right now you just ate, so you're now entering the feeding phase, right? The feeding phase is that now your stomach is full and starts to titrate, starts to grind. It's breaking down the food into small pieces and also mixes the food with acid and enzymes, right? And then whenever it's broken down into 1 millimeter pieces and then pushes it towards your the antrum, which is the last part of the stomach, close to the pylorus, when it connects to the small bowel, right? If it's 1 millimeter piece and then it's allowed to go into the small bowel. This process, depending on how much you've eaten and how much fat and protein was in your food, takes between 2 to 4 hours. After that, you enter the fasting phase, which is very important in the health of the small bowel. The fasting phase has 3 sections or phases. Right? Phase 1 is essentially silence, that kind that enters from the stomach into the small bowel, sits there, and slowly gets mixed with the bicarbonate and also enzymes that are produced by the small bowel and the pancreas. Why? So it gets broken down and gets absorbed. The second phase, which is the longest phase, are just random contractions of the small bowel, just to mix the food without fully propagating the bolus all the way to the colon. That mixes the food further and makes it easier for the food to get absorbed and you absorb all the nutrients. But clockwork, every 90 to 120 minutes, a housekeeper wave starts in the antrum or in the duodenum, which is the beginning of the small bowel, sweeps through the small bowel and dumps everything into the colon. This lasts about 5 to 8 minutes, and that's it. And after that, you enter phase 1, and then again phase 2, and this cycle repeats itself.
How often are patients aware of this?
So, in healthy individuals, the majority of the times you're not aware of it. But when it's not organized and it's vigorous in patients who have partial obstruction, so these waves are stronger and more repetitive, patients can feel these waves with the housekeeper.
What about when patients say, I felt that gurgling? Was that it?
No, so the gurgling can be phase 2 as well. So gurgling can happen in the setting of phase 2 or phase 3. So a gurgling is not necessarily a propagating wave. It can be just a mixing wave. Right. So why is that important? Because on a regular basis, the bacteria that are sitting in the colon migrate into the small bowel. Why? But obviously there's more nutrients sitting in the small bowel as opposed to the colon. So they're living organisms, they go after the food. But on a regular basis, your small bowel with the housekeeper waves pushes them back where they belong, which is in the colon. But when these waves are affected in multitude of conditions, then that's the time that the colonic bacteria come into your small bowel. Now you have excessive amount of colonic bacteria in your small bowel and concept known as small intestinal bacterial overgrowth.
If you were going to give a percentage as to the relative contributions towards keeping the small intestine clear of bacteria and to the following different factors, meaning the motility, the digestive enzymes, hydrochloric acid, and maybe throw bile in there, the ileocecal valve continence.
So those are all interacting together, right? So they're not mutually exclusive symptoms, right? So, I mean, you need your pancreatic enzymes and bile acids, right? But you need your waves for them to work better, right? So it's not that if you
No, I know they all contribute, but relatively, how much do you think what is the most important factors?
So I don't have like an exact number, but if I have to guess, I would say 80-85% of the times, it's an issue with the migraine motor complex that we need to fix, right? And if not more, right? Okay, so let's move on to the next sort of slide. So the key in the small intestinal bacterial overgrowth is that so now we're stuck with an excessive amount of bacteria in the small bowel, which is a relatively inaccessible area. So it's all the way down beyond the stomach, and then on the other side is way above the colon. And now, how do we diagnose this bacterial overgrowth, which is we were going to talk about what tests are available. So, what are the symptoms of small intestinal bacterial overgrowth? Now, remember, there is excessive amount of bacteria sitting in the small bowel, right? So when you eat, instead of you digesting it, the bacteria digest the food. Now, what do bacteria do when they digest food? They ferment, right? They produce gas. They produce hydrogen, they produce methane, they produce carbon dioxide, as you saw, all those gases. So the small bowel becomes full of gas and becomes like a party balloon. But the problem is that the small bowel is not skilled to push air forward. It's skilled to push solids and liquids forward, i.e. food. But the gas, it's really hard to push forward. So it melts it a little bit forward, but then when it lets go, the gas comes back. That's why a very common symptom that patients have is that, oh, I feel like gas is trapped in me. So I can't belch it out, I can't pass gas, and it's just sitting in there. I can't get rid of it, right? And that's one main issue that patients have with distension, of bloating, gas trapping, and also they have erysipelas, dyspepsia, which is sensation of indigestion. Nausea can happen, abdominal discomfort. Very commonly, we hear fatigue in patients with bacterial overgrowth. And now, what is the exact mechanism of fatigue? We don't exactly know, but there is no shortage of studies showing that bacteria-produced side products can affect our acuity of brain and causing mental findings.
You know, it's interesting, when I was looking at some of the other websites that were describing IBS, they described it as spastic colon. So there was this clear sense that they felt it was definitely in the colon. And it's interesting how this research is showing that really in the small intestine.
Yeah, absolutely. I mean, that's obviously, that was the name of the IBS about like 40, 50 years ago, that we used to call it spastic colon. Well, it's not a spastic disease, it's not a colonic disease. If that was the case, you take nobody without any colon in the setting of colectomy shouldn't have irritable bowel syndrome, and that's not the case. So yes, that's a big leap that we have made.
Do you guys have any knowledge of whether the increase in the gas is also increasing pressure against the small intestine, so that it then stops moving even further?
Yes, there's one study essentially.
But can you repeat the question for
So essentially, they're asking if there is excessive amount of gas, does that by itself stop the small bowel from moving efficiently? Is that correct?
Yeah.
So we have animal study data on that. Essentially, if you infuse methane inside the small bowel of dogs, that essentially pushes the small bowel into a halt. It does contract, but the contractions are not propagating, which is a known factor. But obviously, doing that study in humans is a little bit not possible. So, but we do have data in mammals to prove that as well. Yes. So, and obviously we all have heard about this symptom of postprandial brain fog. Patients saying, okay, I eat and for like 2 hours I'm like super sleepy, or I just can't work. I have this patient that comes, he works in a bank, and he's like, I stopped eating lunch because I was making mistakes after eating lunch, so now I just don't do it. And interesting enough, when you get rid of bacterial overgrowth and they're doing fine, they come and tell you that, oh, it's gone. And that's actually one of the first symptoms that goes away in these patients. And it's fascinating that there is a direct correlation. The exact bacteria for this and exact side product of bacteria that is causing this, we're yet to find, but there are multiple studies ongoing to figure out what this is. So there is no universal phenotype in terms of diarrhea or constipation for bacterial overgrowth, but generally speaking, patients with hydrogen sulfide producing bacteria, they have diarrhea and rectal urgency, and patients with methane, generally they have very bad bloating and they can have constipation. But is it impossible for somebody with methane producing bacterial overgrowth to have diarrhea? Yes, it's possible, because it's not just that bacteria sitting in there or archaea sitting in there. There are other bacteria interacting with it. So don't get completely thrown off that it was like, oh my God, this patient has excessive methane and all of a sudden has diarrhea. That can happen, and vice versa with hydrogen sulfide producing bacteria. Another important thing is this: classically we associated small intestinal bacterial overgrowth with weight loss. In severe cases, you start to not to absorb enough nutrients. But now we are understanding even you can get weight gain. And how does this happen is multiple studies again are ongoing. The classic example is in the setting of methane predominant bacterial overgrowth. So what do? Essentially, they break down the food for you, the parts that are indigestible, to a point that some of it becomes digestible for you. So they increase the amount of calorie intake out of the food that you eat. So if I eat, for example, a hamburger that has 500 calories, somebody with excessive amount of methane may get 520 calories out of it. So if we were in a drought 20,000 years ago, I would have been dead, you would have survived. But now in 21st century, that's a maladaptation. So that leads to weight gain and obesity. So that's one of the possibilities that are happening with obesity.
I had a question about constipation, because I've talked to a lot, well, not a lot of gastroenterologists, but some gastroenterologists say that constipation is causing the methane production, or it's increasing your risk of SIBO. But my understanding was that the presence of methane is leading to constipation. So can you clarify that a little bit?
Yes, so I mean, going back to that study actually, so the animal study, I'll start with that and then we'll get back to it. So the animal study showed that even if in the small bowel, if you infuse methane inside the small bowel will essentially come to the halt. So methane by itself is a gas that stops the gut from moving efficiently forward. So it does cause constipation.
My question is, does chronic constipation put you at risk for SIBO?
So what happens is that when you have chronic constipation, excessive amount of stool is sitting in the colon. Yes, there is a component that, yes, you're not evacuating all the methanogens on a regular basis, and they continue to produce methane in the colon. But there is one issue with that though. The colonic mucosa is not as permeable to methane as the small bowel. So you need massive number of methane inside the colon for you to get excessive amount of methane in the breath and also cause constipation, as opposed to small amount of methane in the small bowel that can wreak havoc in us. And more importantly is that we're seeing that the more you have methanogens in the gut, the more constipated you are, right? So that's another fact that points toward the fact that no, this is not a side product of constipation. In fact, it's its own entity. And more probably, if you ask, there are patients with excessive amount of methane who have diarrhea. And that's because of the interaction with the others. So how do we explain that?
Because
Right.
I have doctors who don't want to treat the SIBO because they say the patient is constipated. So they focus on treating the constipation and not the SIBO. And I'm trying to make a point that we need to treat the SIBO so the constipation could go.
Right. Yeah, so that's the argument
I
that
just
you
want to
need
make
to
sure
clear
that
it
I'm
up. Right.
yeah.
But remember, if you use promotility drugs to the point that is moving everything forward, just like how the gut does it, right?
Right.
Even without antibiotic, you can eradicate bacterial overgrowth. So, if you have a very strong promotility drug, and in a sense it satisfies your point of, yeah, you're treating the constipation, but you're in a sense you're kicking out the pathogens as well, and constipation improves for you.
Yeah, somewhere I read, and I'm not sure exactly where, maybe you can expand on this, that the presence of the bacteria themselves produce toxins that actually disrupts the structure of the small intestines, which interferes with the motility. So what comes first? The bacterial overgrowth, it seems, come first, then it interferes with the motility.
So the question is, she heard, or she's aware of the fact that there's this factor that the bacteria secrete endotoxin that affects the motility of the GI tract that allows the SIBO to occur. And so now, how does
Which
that
one
play
is,
into this?
which came first? So, the current thinking is that the dysmotility comes first, because eventually what happens is that the motility of the gut is so efficient that on a regular basis it can move massive amounts of bacteria on a regular basis and push it out. The problem happens when the motility is not good and it can't keep that balance. And that's when the bacteria overgrow, and then they produce the toxin and cause other issues with the, now if you want to talk about the tight junctions, if you want to talk about the mucosal layer, but generally speaking, it's the motility problem that comes first. And now there's like 200 different things that can cause the motility problem.
Okay, yeah, that's what I was thinking.
So it's not like a motility problem is just one thing. So the concept is that essentially bacterial overgrowth is a secondary disease. And that secondary is most of the times due to a motility issue. And that motility issue can be a lot of different things.
When Dr. Pimentel spoke at our meeting a couple of years ago, he explained that you get about a food poisoning with Campylobacter jejuni or some similar bacteria, and that secretes an endotoxin, cytolethal distending toxin, and then the immune system attacks that, and then the immune system cross-reacts and attacks the intestinal lining, and that's what damages the motility, and that's what sets up the SIBO.
Right. So that's essentially the most common cause of sort of this motility, one of the most common causes.
So I'm just going to use my own personal case. So when I was 17, I was given repeated doses of antibiotics for UTIs from using a diaphragm, but they didn't know then that caused it, right? So they just kept giving me antibiotics. So then I ended up with severe constipation, severe bloating, was diagnosed with IBS and told to live with it. Probably was SIBO. So in that case, it came directly as a result of the chronic antibiotic use. So wouldn't that then be the bacteria causing the constipation, not the other way around?
So it's not that simple. So essentially what happens is that when you're taking antibiotic, the fact that how antibiotic can permanently affect somebody's microbiome and not the other. Because right now there are multiple actually nice studies done in infants at least. That they, because infants at least the good thing about it is that you can check daily stool on them and see if what happens over a 3-year time period. I guess 2-year time period. After 2 years, it would like getting a stool sample from them. But in a 2-time time period, what happens with their deep sequencing of their stool? So there are very good examples that when they take antibiotic, long and behold, the deep sequencing of stool dramatically changes. But then after that, slowly comes back to the normal. But there are a group of patients that they get the antibiotics, and it never comes back to where it was. Now, what's the difference? And we think the difference is that there was some mild underlying motility disorder that you get the antibiotic and that's enough to tip you over permanently, as opposed to somebody else, so I'm going to recover in a week because the gut motility can fix problems. Because think about it, for example, you go for colonoscopy, right? You take a full jug of prep, right? That washes a whole bunch of bacteria out, right? The majority of the patients within a week come back and say, now I'm back to my normal bowel movements, right? But some patients come back and say, after that colonoscopy, oh my God, I've never been the same. So we think that's the issue, because think about it. A lot of people take antibiotics. And majority of them go about and nothing really bad happens to the bowel habit, but some patients, unfortunately, like you, end up having chronic symptoms.
You said you're using a term, you're saying deep sequencing of bowel?
Yeah, so deep sequencing is when we essentially get the stool or small bowel, and then we go deep and look for the DNA or RNA composition of the bacteria or even fungi inside that stool. So when you culture the stool, so you can always culture stuff that you can culture. We can probably culture less than 1% of known bacteria and probably less than 1 in a million of like all the bacteria out there, because we just don't have the capability of culture it and then look at it, see what it is. But deep sequencing gives you a better understanding, because now we're picking up the DNA, and based on the DNA inside, we put it in the library, we match it with the libraries and see, okay, what type of bacteria, what type of fungi, what type of even viruses now, or archaea are sitting in the colon. For example, culturing archaea, they don't grow them. It's very hard to grow them. So that's what we're doing. Having said that, now that you opened up that can of worms. So deep sequencing of the stool is a little bit tricky. Why? Because think about it as the sewage of a whole city, right? You're essentially taking a scoop out of a sewage at the end in the river, and you're trying to figure out what's in the fridge of the household and what is that factory doing. It's very messy. So stool is, some of it is like dead bacteria coming from that who died in the stomach, some of it is small bowel, and majority of it are the bacteria in the stool, right? Whether a single bacteria inside a stool, like 3 centimeters away from the mucosa, truly has an effect on us. I don't know, probably not, as opposed to a bacteria that is sitting exactly on the biofilm covering the colon, right? Having said that, all the studies that we have done in microbiome, not all studies, 99% of the studies that we have done on microbiome is based on stool testing and stool sequencing, which is very dirty but accessible. And now the newest studies are using biopsies, and then when you take biopsy, and then you can deep sequence the bacteria on top of the biopsy layer that they're doing, for example. Now, we're going to present data at DDW, if you're interested, Digestive Disease Week in 2 months, and we're mapping the microbiome of small bowel by aspirating the small bowel contents and looking for the DNA of the live bacteria inside the small bowel. Because at the end of the day, colon is a social organ. It's just sitting in there, not doing much as compared to what small bowel doing, which is the engine of the gut, and engine of essentially all the metabolism is happening there. That's where the money is, and that's where the disease association with microbiome will eventually be found. So it was actually very interesting data that we will present at
Which part of the small bowel are you accessing?
So this is duodenum and proximal jejunum. right? And also we have data on now on, because we do double balloon enteroscopy, which is a scope that goes all the way to the end. And we have data on that as well, which, interesting enough, even now we're going to show it as well, there is a full gradient of microbiome in the small bowel as well, just like the whole gut. So the types of bacteria that live in proximal small bowel are different from bacteria in distal small bowel. And when it comes to SIBO, funny enough, it kind of becomes kind of the same, which is interesting. But we're gonna stay tuned on that one. We're gonna present.
I just wanted to point. Oh, I'm sorry. I just wanted to point out that you're mentioning an issue with stool testing, and a lot of us in the functional medicine world do stool testing as part of treating these functional GI disorders. And so there's been a debate in the literature over the last number of years about culture versus DNA, and now a lot of us are using this quantitative DNA, and so you're suggesting that one of the issues with that is that we're seeing DNA evidence of bacteria and parasites and fungus, and some of these may be dead or old and not really relevant, and how do we know what we're seeing is really relevant? And does it matter, like, if there's an amount and it exceeds that amount, is that?
Well, that's a problem with deep sequencing of the stool, right?
Right.
Many studies have done healthy controls, but if you look at in different parts of the world, you can look at the healthy controls, they're not the same at all. They don't even look like each other. They're like different composition depending on what you eat, depending on what diet you have been in the last 2 months, or even if you have had a trip recently, what medications you're on. And so it completely changes dramatically. So it's obviously it's a good evolutionary leap that we now, instead of culture, now we're doing sequencing. Clearly it's more data. But I'm pretty sure in 10 years we're going to laugh at the fact that we looked at stool one day, because now we're going to go to the next step, to the microbiome of probably the biofilm of the mucosa and microbiome of the small bowel. It's just the natural evolution of science and knowledge that moves forward. Is sequencing better than the culture and association of microbiome with disease? Absolutely, right? Yes, we're not going to find another C. diff. The days of finding a single bacteria causing diseases are over. But we have to find the correlation of multiple bacteria and how they work together, and the function of the bacteria in correlation with the disease. And that will probably come when we move towards small bowel microbiome and the biofilm microbiome.
You mentioned in great detail the process of eating, the food going into the stomach, acid and enzymes and so forth. Getting the food to a point that it is micronized, if you will, in order to be absorbed. However, you didn't actually speak about insufficient mastication. So how much of a contributor is that, especially in a society that probably doesn't take enough time to chew their food?
And that's a great point. I always bring it up with the patients.
The question is, what role does how well you chew your food play in this?
Actually, big. But interesting enough, and I always bring it up with patients as well, breaking down the food with mastication and breaking the food. And also that there are multiple enzymes that are already being produced in your mouth as well. And that also mixes that up with the enzymes inside the mouth that you're swallowing. But interesting enough, there's not much data on that, and that's some area that definitely needs further testing and studying. What is the role of me gobbling a hot dog in 30 seconds, and rather than like chewing it and get it correctly in terms of GI symptoms. So that's a very valid point.
You mentioned a couple of times that those a motility problem, and how you can potentially just use the motility agents instead of antibiotics first. So how long would you use motility agent for that? Probably should do.
Depends on the underlying cause, right? So
I feel like you can just activate motility apparatus and then not like stop
Yeah, there are multiple cases. So I guess maybe I'll just open that talk, that what causes the motility issues, right?
Yeah.
So depending on what's affecting the housekeeper babes, and then you can do different interventions to get those housekeeper babes back to the patient. That's easier said than done, but if you're successful, most of the times that's enough. If you're successfully giving them back healthy housekeeper babes to the patient, for them to kick out the bacteria, you don't even need antibiotic in that situation. So the most common cause was just what you mentioned, is that when you pick up a gram-negative bacilli infection, such as Campylobacter, Yersinia, or Salmonella, E. coli, these have a unifying protein inside them, which is called cytolethal distending toxin, or CDT. So the component that is tricky is CDTB, the B part. So just like any infection, when you pick up that infection, you develop antibodies against that CDTB. So it's called anti-CDTB. The majority of the times we develop these antibodies and they just wear off and then that's it, right? But unfortunately, this anti-CDTB attacks another protein in our body called vinculin. Because CDTB looks like vinculin in our body, so body through this molecular mimicry gets confused. So now you produce auto-antibodies against vinculin, which are called anti-vinculin. So the problem is that now you have anti-vinculin against a protein that is endogenous in your body. So body is not going to forget because constantly it's being exposed to vinculin. So now you have auto-antibody. So vinculin is also involved in the function of interstitial cells like a halt, which are the enteric nervous system of the gut, which are the nerves that feed the small bowel and also the rest of the gut, and helps for the small bowel to have propagating waves, right? So now you have anti-vinculin levels and ICCs don't work, and the first thing that gets affected is migraine motor complexes, right? So that's, for example, one thing that we see. When we see super high levels of antivinculin, right? These are patients that essentially go beyond SIBO sort of picture. They become like a pseudo-obstruction picture. The small bowel becomes a super distended. These are patients that get hospitalized multiple times, and that's really bad. But then the antivinculin levels are lower. These are symptoms of patients with mild symptoms. These are the symptoms that, for example, with a pro-motility drug that activates migraine motor complex, you can fix them. For example, low-dose erythromycin at bedtime as a motility agonist, right? Or 5-HT4 agonist, for example, prucalopride, which is coming to the market in 2 months. Or drugs like Intestinal, which is a acetylcholinesterase, so it stops the acetylcholine to break down, so it activates, it works like the vagus nerve, and then it causes migraine-motor complexes, or octreotide. So with those, you can push things down, and you don't necessarily need antibiotics. But when the antivinculin is super high, then those are the patients that you put them on pro-motility drugs. You put them, you make them NPO. You give them antibiotics, and they're still symptomatic. Those are the ones that it's very hard to treat. So that's one example of, to answer your question, that whether we use only pro-motility drugs depends on the situation.
Is that a simple blood test for the vinculin?
What's that?
Is it a simple blood test for vinculin, the antibody?
Yes, there is a simple blood work that you can do anti-CDTB and anti-vinculin levels. Yes.
I just want to make a comment, and I don't know if there are any studies that's being done on this. So I've been chelating patients for the past 10, 15 years. And what I noticed in the age group between 20 to 50, they're loaded with mercury. And when I pull the mercury out, the motility actually improves. And a lot of these patients who have had IBS or SIBO, recurrent SIBO, it just goes into remission. So I was wondering if you can make a comment on that. Are there any studies?
Not that I'm aware of. yes, mercury and mercury poisoning has been associated with motility being affected. But now, exactly, for example, if we go back and like Target 3 trial, 2,500, for example, IBS patients, and see how many of them had elevated levels of mercury, we don't have studies similar to that.
The other question I have is, in one of Dr. Pimentel's lectures, I heard that the weight gain was due to insulin resistance. Can you explain that? How does SIBO actually cause insulin resistance?
So we don't know the exact pathway, the insulin resistance. So what we did was that in the setting of methanogens, we checked whether in two different studies. We looked into patients with diabetes and without diabetes. So patients who have excessive amount of methanogens, their response to insulin is different, right? And also patients who undergo bariatric surgery for weight loss, if you have methane, they lose weight harder than patients who don't have methane, and they had some issues with insulin response as well. Now, how exactly the methanogens affect the pathways with response to insulin is yet to be defined how that works.
The food getting from the stomach into the small intestine is acidic. What happens with patients who are on proton pump inhibitors?
So actually, the body is very amazing. So on average, by the way, do you know how much acid we produce per day? Do you have a guess? So it's actually half a gallon of acid we produce per day, 2 liters. And the pH of the acid is actually 2, right? Inside the crypt is actually 1.4. So if you put that acid on my laptop, by the end of this session, there is no laptop. So it's, huge amount of acid that's produced per day. But the fascinating thing about it is that the minute the chyme enters the duodenum senses the acidity, sends signals to pancreas and produces bicarbonate, and bicarbonate pours through the major papilla, which is about like 5 centimeters away from the pylorus, right? And bicarbonate comes and neutralizes the acid, right? But that response is dependent on the acid. So, whether you're on PPI or not, the pH of the duodenum in 10 centimeters is exactly the same, because the body adjusts it. So it's not like now you're more alkaline because you're taking PPI. And that mechanism is fascinating. And think about it, if that mechanism wasn't there, a lot of drugs that we take that are pH dependent wouldn't work. And somebody with PPI
associated with increased risk of SIBO.
So that's debatable. That's the problem. So I can show you. So the question is that do PPIs cause bacterial overgrowth? So which is actually interesting because there are multiple studies saying yes, there are multiple studies saying no. But I'll tell you, we wanted to actually close this chapter, and actually I was on the side of the people saying that yes, PPI does cause the bacterial overgrowth. So again, in DDW in 2 months, sorry, because of the data embargo, I can't say it. We checked it in 300 patients, and PPI do not change the composition of the small bowel to a point that we thought is actually don't cause SIBO. And I think it's because of that mechanism. That small bowel has its own system to control its pH.
But how long were they on the PPIs?
Oh, years.
But does it change
does-
the amount of bacteria that comes through?
It does, but again, I don't exactly know how again small bowel keeps controlling, but obviously there are other control systems that we don't know. That study actually was to our all-out surprise, and you will see the details of it. Because we went in there to show that yes, patients with PPI as compared to no PPI, there's dramatic difference in the bacterial composition of the small bowel, and there isn't. And we're like, what happened?
But what does that say about the hypothesis that the hydrochloric acid helps to keep the small bowel free of bacteria? Maybe it doesn't.
Just breaks down food.
makes the hypothesis more debatable, I guess. I don't know what to tell you. So again, clearly jury is out on that concept. I guess that's the point I'm making, and we need more data and more understanding of what's going on with that. Okay.
Yes. Is there any data on the existence of gluten intolerance and the incidence or current prevalence of SIBO?
So not gluten intolerance, but clearly there is an association between celiac and small intestinal bacterial overgrowth. No question about that. There are multiple studies showing that. Now, whether this is because of, well, celiac patients are different from gluten-sensitive patients, or wheat-sensitive, if you want to call them. Celiac patients have significant amount of inflammation, and we know that inflammation affects motility.
Right.
So obviously that predisposes the small intestinal bacterial overgrowth. Now, is there data on wheat sensitivity / gluten sensitivity with bacterial overgrowth? At this point, I'm not aware of. Is anybody aware of that data? Not that
So
I
what is
know
the
of.
difference between having 2 genes for gluten intolerance that are non-celiac?
Mm-hmm.
I mean, what's the difference in the physiology of, I know the celiac is more severe, but aren't you getting, isn't there a spectrum? I mean, aren't you still getting the same physiological process which would lead to interruption of the motility of the gut?
Not, well, at least not microscopically. So patients with gluten sensitivity, by definition, if you biopsy the villi is healthy. They're looking at it. Now, you may argue, but villi may look normal, the tight junctions may be abnormal, so that needs to be determined. But as compared to celiac patients, when you biopsy the villi and you look at it, they have flattened. There are increased amount of lymphocytes sitting in there. There is mucosal injury. You're correct, probably there is a spectrum of disease, just like any other diseases. We haven't broken it down to a point that we can say that, okay, is there an inflammatory component of gluten sensitivity with a non-inflammatory? We don't know yet. And more importantly, we haven't done any research with C what it is.
Will you be speaking about the FODMAP diet and food and all that too?
On this one, no.
Tonight, we'll talk about the FODMAP diet.
We can talk about FODMAP diet, but we can do that here. Right. Well, I mean, that's a whole another talk that we can talk for hours about it. But specifically speaking, just put it in a nutshell, FODMAPs is built upon the fact that these are not to eat fermentable food. Food that essentially fertilizes the bacteria and the gut microbiome. So, and not eating it leads to alleviation of symptoms of bacterial overgrowth and irritable bowel syndrome, obviously. Now, how long do you continue with FODMAPs? That's another story. And now the guidelines are that within 1 month you should start to reintroduce FODMAPs. It's not necessarily a healthy diet. You can be on it lifelong. And multiple studies have shown that within 3 months you may start to have some micro and macronutrient deficiencies that within long term may harm you. So it's a good diet to start to see that, okay, can I tease out what specific food item kind of affects my gut symptoms, and I take that out specifically out of my diet, as opposed to being on strict FODMAP for the rest of your life.
Now, Dr. Pimentel, correct me if I'm wrong, he doesn't believe in changing the diet while you put the patient on antibiotics.
Yes, so there is that concept as well. There is a pragmatic way around it, and also a theoretical sort of benefit as well.
He says the bacteria should be well fed while you're trying to kill them. And then he sometimes recommends a low FODMAP or a low fermentation or some other similar diet maybe afterwards. Whereas most of us in the functional medicine world, we usually are using herbs, so we're putting the patients on a low FODMAP or an SED or similar sort of diet to try to starve the bacteria at the same time that we're trying to kill it. But that's because herbs potentially, we think, work by a different mechanism than antibiotics work, right?
Yeah. And also remember, when you're taking antibiotics during that 14 days, A lot of patients have diarrhea gets worse, symptoms, die-off type of symptoms that they get. So they're already miserable, and telling them to go on FODMAPs on top of that makes those 14 days really like not the happiest days. So from the pragmatic point of view, that makes sense as well. And also, obviously, there's a theoretical sort of potential reasoning behind it. So you want to feed them so you can kill them.
Well, just out of curiosity, in your world, when you do get a patient that's positive for SIBO, and they say, look, I don't really want to take antibiotics, and then you say, well, why don't you take this low dose erythromycin? And they say, I don't want to take antibiotics. Do you ever recommend just diet as an intervention?
So we do diet as an intervention. I have to say, patients who come to my clinic, by that time, diet is not going to cut it, right? We obviously in that situation, I put the management of small intestinal bacterial overgrowth in a sense in 3 pillars. Pillar number 1 is understanding the underlying cause. So I try to see if there is a modifying underlying cause that I can fix, right? If patient comes in and patient is on narcotics and narcotics can be taken out, well, the problem solved, right?
In case everybody's not aware, narcotics decrease GI motility.
Right. So looking for that. And then I'll go for induction of remission, essentially killing the bacteria, and then maintenance of remission. So for induction of remission, options are synthetic antibiotics, herbal antibiotics, and also elemental diet, right? For maintenance of remission, essentially you have pro-motility drugs as well, and also the diet, right? So if patient comes in and absolutely doesn't want to take antibiotics, whether synthetic or herbal, usually my go-to approach would be an elemental diet, and usually that's so if you take it about 14 days, that has in a case series in its non-control trial has been shown to have a efficacy of 75%. If you take it about 21 days, that has an efficacy of 90%, which is more than any other antibiotic. So that's the option that I bring it up to the patient.
And which product are you using for elemental diet these days?
Usually I use Vivonex Plus. The Vivonex. Vivonex Plus, VIVONEX.
Does the fax crystallize by the time it gets to the colon?
Correct. Yeah,
So
exactly.
it doesn't kill the microbiome?
No, so that has been shown. Supposedly, no, actually, no, it doesn't.
What
So,
did she say? I couldn't-
The question is, does rifaximin negatively affect the microbiome?
So, the interesting thing about rifaximin is that it's active in the small bowel, and then it crystallizes in the colon. So it's essentially inactive in the colon, which is a fascinating concept. Actually, that tells you right there that IBS is not a colonic disease; it's a small bowel disease, right? So 2 things I can tell you about that one. So number 1 is that now we presented this data in American College of Gastroenterology conference last year, that the only determinant of response in patients who were treated with Xifaxan, in 2,500 patients, was red testing. Essentially, the only determinant of response of IBS patients getting better on Xifaxan was probably the abnormality of small bowel microbiome. So that's one thing. So that kind of confirms the fact that Xifaxan is active in the small bowel, so that's what it does. It's another thing is that during Target 3 trial, 105 patients underwent deep sequencing of the stool. And the deep sequencing of the stool was checked at the beginning, after open label therapy, which is 1 round of Xifaxan, and then before the randomized dose, which was the 2nd round, and then at the end of the 3rd round of antibiotics. So 98% of stool microbiome remained exactly the same before and after Xifaxan. So that tells you one thing, saying that, well, it's an antibiotic, it's killing something, but it's affecting the small bowel, and the contribution of small bowel to the whole stool microbiome is relatively very small. And that's another point about, I told you that in 10 years we're going to laugh at each other that one day we looked at deep sequencing of stool, and that's another point that I'm making, that as we move along we learn more, we know where to look for in terms of assessment of microbiome.
I know you talks about breath testing, but when do you use breath testing versus the serum testing, or do you use both? Or
Oh, they're complementary. So remember, not everybody with antibodies gets SIBO. Not everybody with SIBO is having SIBO because of this antibody. So there are like two different concepts.
okay, so
Yeah.
the serum test is just to figure out what the origin of the SIBO is.
Yeah. And at this point, it does not tailor the management. Breath testing tailors management.
Because you have to use a different treatment if it's methane versus hydrogen, and now
Yeah.
with the new breath
Yes.
test that you guys are developing with
Absolutely.
hydrogen sulfide,
Absolutely.
right?
So they're complementary. They're not. They don't answer the same question at all. Yeah.
And the MMC medications, how long are you typically using them?
Well, again, the good thing about MMC medications is that if you stop it and you restart it, it's not like you become resistant to it. So generally speaking, we try 3 to 6 months, and then we give the patient a little bit of a honeymoon. The patient is maintaining their health and no symptoms. We'll look over it. You don't need it. Just be careful not to get another food poisoning. But if symptoms come back fast and furious, we restart it. So, yeah, it's just you have to play it by ear.
Have you looked at the efficacy of any of the nutritional pro-motility agents on the market? In the SIBO world?
Not necessarily. We haven't done any formal study. Doing formal studies on pro-motility drugs are extremely hard because essentially you have to do an anti-renal manometry on them and see how it works, right? And that's an invasive test. It's 6 hours of test that's like something is sticking, It's a very tricky business to see exactly the migrating motor complex.
Are there any tests coming on the market soon to measure motility?
With migrating motor complex? No, unfortunately, no. There are multiple studies that they're trying to figure out whether by the sounds of the gut you can figure out which wave is migrating motor complex. They're in their infancy. Hopefully in future we will have something, but nothing prime at this point that I know of.
So I've seen a few patients who have like a reverse problem. Obviously, it's probably the sulfate predominant SIBO, where they have diarrhea. But from the moment that they take something into their esophagus, from the moment they start eating, they're getting cramping and they're getting diarrhea. What is happening there?
So eating and movement of the gut doesn't start when you put the food in your mouth. The minute we look at the food, the vagus nerve activates.
Right.
So, and the vagus nerve is priming the gut and that's called the visual part of swallowing or the cephalic part of swallowing. So you're just looking at the food and you're making the decision to eat. That's when the vagus nerve kicks in, right? And tells the pancreas to produce enzymes, tells the gut to move things forward, right? And that's why that the minute that they eat, they already gut has started its engine to move forward, and some patients get sort of diarrhea. On top of it, there is a gastrocolic reflex as well. So when the stomach distends, sends a signal to the colon, say that hey, more food is coming. Empty yourself out, and it's time to empty the colon. That's why in kids, for example, or infants, you probably notice that they have milk and then they have a bowel movement. Or kids, they have their food and then they run to the bathroom. That's the gastrocolic reflex. As we grow older, that gastrocolic reflex becomes less prominent. Interesting enough, that gets accentuated again in IBS patients. Now, how that pathway has been activated, we don't know, but that's part of it as well.
So does that mean that most of what we've been discussing has to do with the methane-producing version of SIBO? And what are you doing for the diarrhea version?
No, in terms of treatment, you mean? No, the treatment for methane is, for example, antibiotics, and that 3 pillars that I mentioned applies to all of the categories. It's just that the type of antibiotics that you use is different. In terms of pro-motility drugs that you use, they're the same. The same thing that you use. Yeah.
Along the same lines, if someone's having diarrhea, why aren't they emptying the hydrogen sulfate bacteria more if they're pooping all the time?
That's $1 million question. Well, obviously the body wants to do something, but it's incapable of it. So one sort of plausible answer to that is that it's all the way in the small bowel. And no matter how many bowel movements you have, some of it, they still stay in the small bowel and continue to repopulate. So that's another thing. So because think about it this way as well. Why, if this is the excessive amount of bacteria, when we have the 4 liters of colon prep, they still all of a sudden the symptoms of SIBO comes back within 2 days. Because obviously they know they weigh around. This is one thing that I always tell the fellows as well, is that we have been around for a few million years, right? The bacteria have been around for like 500 million years, so they have figured this out. They know where to hide, they know what to eat, they know how to survive, and they know what to produce, and they know how to compete with the other organisms. And they're sitting in there and they look at us as just a host, right? They don't want to kill us. They just want to sit there and enjoy the food that we give them, but obviously they produce some symptoms. So that's one point that you need to keep in mind as well, right?
And would you give them different pro-motility agents versus the methane type?
Obviously, in the methane patients, we go higher doses of pro-motility agents, but in terms of what type of pro-motility agent that I use, generally I use the same thing.
They have more diarrhea when they do that?
They do, so that's why you should be careful with the hydrogen sulfide producing and hydrogen producing bacteria. So starting with the low dose and starting wrapping it up. Obviously, these are all anecdote. There is only one tiny case series that was published in terms of the effect. For example, low dose erythromycin almost doubles the time to recurrence of bacterial overgrowth.
So the confusing thing is people normally think of constipation as decreased motility and diarrhea as increased motility. But what you're saying is there's a difference between diarrhea and the motility of migraine motor complex.
Right,
is that what the distinction is?
So that's a simplified concept, and it's not necessarily correct. That you're constipated, so your bowel movement and contractions are slow. No, sometimes they can be super fast. They're just not contracting, propagating. They're not pushing things forward. They're just random. Sometimes retrograde. We have patients with colonic inertia that we see a few every year. These are patients that we do colonic scintigraphy. Essentially, we do a colonoscopy, we put a catheter inside the colon, and then we took radioisotope of indium and technetium in each part of the colon, and we wake them up and watch them under nuclear imaging how this moves over 3 hours and after eating. Some of these patients, these contents goes backward. It just goes retrograde. Some of them goes all the way to the terminal living. So there is retrograde contraction. So it's not like the bowels is like stagnant. No, it's actually doing the opposite of what it's supposed to do. And the other side applies as well. Not every diarrhea is because of the fact that it's moving too fast. No. Sometimes when it's completely stagnant and it's not moving at all, in fact, actually you get diarrhea in that point. So it's not that simple and clear cut.
And by the way, the definitions of these terms, is controversial too, right? So you can have somebody who's constipated and they could be going to the bathroom 4 times a day,
right?
But just not hardly anything's coming out.
Exactly. So that how patients describe it is completely different. So you definitely have to tease out, see what exactly patient means by constipation and what exactly patient means by diarrhea.
And what do you mean by constipation and diarrhea?
So by constipation, I mean infrequent bowel movements, less than 3 times per week. So that's the definition of constipation that I'm talking about. So that's what I mean. Yeah.
So I had a patient who came to me, when she showed up in my office, she's dying to get pregnant. She was on 10 Dr. Schultz intestinal formula number 1 a day. You familiar with the formula?
Yes.
What was she on?
10 Dr. Schultz intestinal formula number 1 a day.
Oh, okay,
to
a
poop,
herbal
to make
laxative
movement.
type of
The
thing?
strongest herbal laxative
Okay.
that's on the market, and to have bowel movement at all.
Right.
We've gotten to where she can do 4 colacs a day and be able to go, but she's not going to be able to take purgatives when she's pregnant. Her SIBO test, the flattest line I've ever seen, which surprised me.
Right.
So where do you, in your mind, go next? Would it be to a colonoscopy looking at motility? Where would you go next, just in your thought process?
So, yes, obviously, when you are looking at somebody that is taking 10 sort of laxatives a day and still is symptomatic, obviously that's the time that you have to look into more significant diseases like colonic inertia and something that is now beyond really the common things. So that's something that you need to.
She'll be coming to see you.
Yeah.
You're right.
Yeah. And obviously, a lot of things in this situation, the pelvic floor dysfunction, patients with large rectus interstitials, and
She just had 2 cysts removed about this big around her ovaries, not on it. Could that cause constipation? Not on the ovaries.
Endometriosis or not just a simple cyst?
Simple cysts.
Shouldn't do it.
That shouldn't do it. That's not big enough.
Yeah.
But you can also have scar tissue that can affect the colonic motility, right?
Yeah,
Scar
absolutely.
tissue could be from, could have fallen and hit your stomach, or somebody hit you, or...
Yeah, definitely. You can have scar tissue, essentially adhesions, intra-abdominal adhesions that can affect the small bowel or colonic movement. And yes, the majority of the intra-abdominal adhesions are caused by surgery, but you can have de novo. It's not necessarily de novo. Essentially, you can have intra-abdominal adhesions in virgin abdomen. Right. That can, the most common cause remains the endometriosis, for example, that you get endometriosis and it obviously causes adhesions. Fitzhugh-Curtis disease, undiagnosed appendicitis that happened and was never treated type of, so it's not uncommon.
Or
to see that.
hernias.
Hernias can affect the motility as well. That's correct. Yes.
I have the SIBO test. If someone has all the symptoms and it's very clear they're constipated or very clear they have diarrhea, why do you need to do the breath test? Like, what extra information do you get?
So that's the thing, right? So the thing is that not everybody with constipation is SIBO. Not everybody with SIBO has constipation or the
Yeah, of
diarrhea,
course,
right?
but if you see that fullness and it's the upper bloating and they're very, it's just the whole, it's just
The whole
something,
spiel.
patients when they're so clear, is there a reason for the test?
So the only reason would be is that obviously, no, but you have a point. You can do empiric therapy, but the thing is that, well, for example, if you have methane predominant bacterial growth, you probably want to treat the most common thing being Xifaxan and neomycin, right? We know that Xifaxan, the risk of, for example, C. diff is very rare, right? In 1 in 3,200 in randomized controlled trial, very rare. But neomycin is not that rare, right? So if you treat the patient and the patient doesn't get better and then comes back with C. diff, like that's not going to be like a good situation. But again, neomycin. Because of the antibiotic.
Oh, I just use them.
Oh, you do? Oh,
Yeah, I
okay.
use herbs too.
Okay, so
I don't necessarily need it unless I wasn't clear if they even had it, but if it's just completely
So,
uses.
yeah, you have a point. I mean, you can empirically treat, but it's just obviously less informed, sort of like a decision making. But you know, we make those decisions every day in the clinic. That whether it is setting off, whether it's for the financial issues because of the time issues, patient is flying tomorrow to whatever, and you just go ahead and
Yeah,
treat.
in some cases it's like so clear, and I'm like, is there anything I'm missing that I get from the test?
Well, in general, a lot of the lab tests are done to confirm the suspicions we already have.
But then, is it a breath testing miss certain percentage of cases that people here who test treat anyway?
So so any test has a certain sensitivity, right? And the true sensitivity of it is a little bit hard, and actually we have some data on that one with deep sequencing. So I can tell you right now the sensitivity is about 90%. But having said that, yes, there are, if you add hydrogen sulfide on top, the sensitivity essentially shoots up to about 90% or plus 90%. But still, it's not 100%. But that's the story of any test in medicine. And remember, not every bacteria in our gut eventually produces hydrogen and methane, right? Not every bacteria produces hydrogen sulfide. There are bacteria that are out there that are causing trouble, but you don't even, they don't even produce any of those gases. These are tests that to kind of help you sort of make a more informed decision, but it's not that if you do you have a normal breath test, that's the end of story on that one. You have to like put your medical judgment on top of it and make your decision on that.
Well, I actually thought it was more than 10%. I thought it was 20%, but I like 20% like in terms of how accurate, how sensitive it was, but
I'm adding hydrogen sulfide on top. So hydrogen sulfide adds extra 15% on hydrogen and methane.
got it.
That's a test that's not currently available.
Right, not available, but it will be.
Because I know like some of my patients who have tested negative ended up getting treatment, whether it's like cosmetic or antibiotics, and got better.
So I can tell
your test was negative.
Yeah, so I have some data that I will show you. It's actually, I have a graph on it, and that will answer your question. There is a subgroup of patients that they respond to, even in randomized controlled trials, to Xifaxan, for example, even though the breath test was negative, but they're dramatically lower.
I think we better let you get to finish your presentation.
This was the longest slide ever. Okay, so let's talk about small bowel aspiration as the gold standard that we know. And so, I mean, we had this North American consensus that we put together, okay, how do we standardize breath testing? And one of the things came up was like, okay, we always say that small bowel aspiration is the gold standard, but is it? So I go in there in the small bowel and aspirate like 2 inches of small bowel, and I hope that that represents 20 feet of small bowel. Well, that's just naive, that it won't do it, right? So the problem is that we don't have a gold standard test for bacterial overgrowth because we don't have a test yet that can assess the whole small bowel. On top of it, obviously, small bowel, I mean, I do a lot of small bowel aspiration, but I'll tell you right now, it's invasive, it's costly, it's time-consuming, and there's sampling error to it. And another problem is that when you're going to the small bowel, what do? You go through the mouth, and you're going through this esophagus. So you're dragging all those bacteria with the upper respiratory tract, and if you're not careful of cleaning your scope, and if you're not careful with, and you have suctioned a little bit of a juice in the stomach, you're actually sampling a contaminated sample. Now we have a specific catheter that has a double lumen that we use, so it's not contaminated. But that adds extra time to it, but at least we know for sure it's not contaminated. So the small bowel aspiration is a little bit tricky, but on the other side, it's helpful in multiple ways as well, that breath test can help you in the sense that it can pick up non-hydrogen or non-methane producing bacteria. Also, you can culture the fungi, right? Because breath testing is not going to pick up SIFO, but aspiration is going to pick up SIFO.
SIFO is small intestinal fungal overgrowth.
Yes, correct. Alright, so that's the difference. On the other side, breath testing is non-invasive, it's relatively inexpensive, and the advantage is that it's based on, it gives you a clue about the whole small bowel, as opposed to 2 inches of aspiration in the small bowel, which is, I would say, in my opinion, the biggest advantage of breath testing over a small bowel aspiration. Okay. So yeah, so that's essentially the point I wanted to make, is that you take that small amount and then you're taking the sample. Okay, so you kill that slug. No, so this is just explains, if you can go a couple back. No, go back. All right, yeah. So this is how breath testing essentially works. We already talked about it. You take the sugar substrate. The sugar substrate gets fermented by the bacteria, and some of the hydrogen and methane, and also hydrogen sulfide, comes back onto your lungs, and then you breathe it out, and then we measure sequentially how much hydrogen and methane you're producing over a 2 to 3 hour time period, and that tells us whether you have excessive amount of small bowel or not. Okay, move on. Okay. So again, this is something that helps us sort of standardize the breath testing for us in terms of indications, preparation, performance, and interpretation. So this is it's open access. You can download it. It's a good source. So let's look at the normal breath testing that usually happens. So as you move along, you can just click multiple times so I can just show it. So generally speaking, patient goes on a bland diet the day before, and that's kind of helps bring down the amount of fermentation so you have a low baseline. And then fasting overnight. So again, you now count the hydrogen-producing bacteria a little bit further. So generally speaking, we expect to see a hydrogen lower than 20 at baseline and a hopefully low methane. And as the sugar is consumed, you see that there is no excessive rise of gas throughout the test. At the end of the test, always there is a little bit of a rise in the hydrogen and methane, not always, generally it increases, and that's because of the colonic fermentation. Eventually lactulose finds its way all the way to the colon and starts fermenting, which is normal, happens in all of us, which you will see that as well. If you use glucose, you won't see that because glucose gets absorbed in the first 2 to 3 feet of the small bowel. But it won't reach the colon, so you won't have a false positivity of colonic fermentation, but the other side, you're losing data on 15 feet of small bowel, right? Okay. So this is when hydrogen-producing bacteria are excessive. So generally it takes about 105 minutes for the lactulose reaching the colon, and by the time that actually lactulose reaches the colon, then it takes about half an hour-ish for the bacteria to produce a gas. Because it's not that right away to produce gas the minute that they're exposed to sugar. They're living organisms. It takes a while for them to take it and metabolize it and ferment, right? So it takes, generally that's why we rarely see the colonic fermentation. But if it happens earlier than 90 minutes, with high degree of certainty, you know that it's happening in the small intestine. So in this patient, it rose from 8 all the way to a 42, and that is more than 20, which is the cutoff, and that we consider this test positive, right?
But if the rise happens between 90 and 120, that's a controversial.
That's when your medical judgment comes to your place. That, okay, should I treat this patient? Is this a little bit of a slow transit and bacterial overgrowth, or this is a colonic fermentation, or it's a fast transit? So that's when you put the medical judgment hat on top and decide what to do. All right. Okay. And we're going to talk further about this as well. And this is somebody with methane-predominant bacterial overgrowth. Generally speaking, patients who produce methane, even after fasting, they still produce methane. So methane here is 42. Anything above 10 right now we consider abnormal. Now between 3 and 10, the jury is still out, but definitely above 10 we consider abnormal. So this is an abnormal methane testing. So obviously there is some data out there that say that, okay, specificity of breath testing is not good because it just measures colonic fermentation and not small bowel fermentation. This is actually a meta-analysis with Dr. Rao that I did. And these are all healthy individuals. All the studies that included healthy controls in the and their breath testing. Okay, if you look at it, the overall specificity was 85%, and if you look at centered studies that were done with more than 60 subjects, the specificity was 95%. So essentially, when you know what you're doing, you do a good job. So you do the right prep. You do make sure that the patient is fasting. But obviously, if you look at the there are some outliers here, right? So people who can who essentially talk about specificity. I'm trying to not. All right. So obviously. There are a couple of studies here that you can see that clearly are outliers, and people who don't like breath testing clearly always just take these two tests and two studies and run with it and say that hey, it has an excessive amount of, it doesn't work. Well, I mean, look at the rest, man. But another point that I wanted to make is that these, when you say specificity, that may give you an idea, okay, 50% are false positive. Not necessarily. Not everybody with small intestinal bacterial overgrowth is necessarily symptomatic. Not everybody with H. pylori in their stomach is symptomatic. Not everybody, there are patients out there with bacteria in the urine, bacteriuria, that they don't have any symptoms. So having a positive breath test and bacterial overgrowth doesn't necessarily mean that it was a false positive. It's a patient that is tolerating that bacterial dysbiosis, no problem. Now, why some patients tolerate it, some patients don't. Why some patients take antibiotic and it's the hell breaks loose. Some patients don't. Those are the parts that we don't know. All right. So we talked about this, you can just click multiple times. I talked about this essentially the 3 pillars of management. Obviously, this is a very simplified approach. We all know that single patients they usually are more complex than this. Go ahead.
Have you heard about like using Zenfaxin but more than 2 weeks and like tapering?
So obviously that's an off-label use. But yes, so in refractory cases, that's definitely an approach. For example, 1 tablet or half a tablet that can be used on a long-term use for patients that recur on a very excessive amount.
1 tablet of what? Sorry, so hard to hear here.
Okay. No, so she was asking is Zenfaxin can only be used the way that is prescribed in the Target 3, for example, 14 days, 3 times daily, or it can be prolonged. It can be prolonged, but obviously that's an off-label use, and that's an approach that we use in patients with refractory SIBO, or the SIBO patients that say that you take the antibiotic, the minute they stop it, all the symptoms comes back within 2 days, and that's and we can't control that with motility drugs. That's one approach that can be used.
Yeah. So, I know I'm sure you use neomycin a lot because of where you work, but do you see a lot of ringing in the ears with neomycin?
I've used like thousands of prescriptions of neomycin. I've yet to see one. Yeah. Obviously, I counsel the patient about it. But clearly it's a rare phenomenon. Yeah.
How can the use of flagyl? So I'm a pediatrician, and a lot of the gastroenterologists that I send my patients to, they get diagnosed clinically. They don't do the breath test, and they do 14 days of flagyl. Sometimes the patients respond, and sometimes they don't. So can you talk a little bit about that?
So, no, flagyl is an acceptable choice as well. So the only issue with flagyl is that a lot of patients get nausea with it, right? So nausea is one big problem with it. Otherwise, flagyl is an acceptable choice instead of neomycin.
For bovo methane?
No, just for methane. Yeah, so for hydrogen, I would use flagyl because the majority.
Just for methane.
Yeah. So hydrogen-producing bacteria, the majority of them are not anaerobic. Right. So you don't need flagyl for it, right? Because flagyl kills anaerobic bacteria.
No, right. Yeah, so if they're failing, it could be that they have the hydrogen producing, because these are kids who are not getting tested necessarily.
Yeah, absolutely. Yeah, that wouldn't be my first choice as a single drug for sure. flagyl would be preferred.
And what are you using for the hydrogen?
So the hydrogen amine sulfaxin is one option you can try. Doxycycline has been tried, erythromycin has been tried, azithromycin, there is data on it, amoxicillin, there is data on it, multiple choices that you have.
I had a patient with hydrogen elevated, and she had malnutrition, and they were heading off on a world tour for a year. So she went ahead and did rifaximin and waited about, she was leaving like Sunday, and she finished the antibiotics Tuesday, so she waited as many days as she could and retested and sent it off, and her levels came back higher. How often do you see that?
Yeah, so those are the top ones, that essentially eradication. So in those situations, if the patient hasn't responded and your breath is now worse, time to switch gears and don't use rifaximin. You have to try some other antibiotic or other approach management.
So we try anyway.
So that's the
But
time.
it does happen sometimes?
It does happen.
And how long should you wait after finishing the antibiotics to retest?
Well, usually what we recommended was about 4 weeks, but you didn't even wait that long and it was high. So, that's all good.
And how do you tease out sucrose sensitivity? And then also how do you test for SIFO? And how do you treat SIFO? Do you treat together with SIFO?
So for sucrose sensitivity, essentially you can do a sucrose breath test, and also there is genetic testing as well that you can do. So essentially, if you're worried about that, you can do those tests. And there is sucrate now that you can use it to see if it helps the patient. In terms of small intestinal fungal overgrowth, I do aspiration. I do small bowel aspiration because I find the stool test unreliable because we all have candida in our stool. It's supposed to be there, but it shouldn't be in the small bowel. So if I go in there in the small bowel and there's like 2 or 3 plus candida all of a sudden sitting in the small bowel, that's when I treat the patient. So that's.
Do you do that only after you've treated SIBO and they are still bloating, and then you do this?
Yeah. So in my experience, definitely SIFO is less prevalent as a small intestinal fungal overgrowth. And if I'm getting over with bacterial overgrowth, the patient has symptoms, that's the time that I do endoscopy with small bowel aspiration to see whether I'm dealing with a refractory bacteria or an unusual type of bacteria or fungal overgrowth, or there is nothing else. I'm totally off. There is something else going on, right? So that's.
And what are you using to treat that?
So the treatment usually is a fluconazole that is recommended for therapy. You can use oral nystatin as well. There's no real data on it. The sensitivity testing of fungi against nystatin, interesting enough, not well recorded. But that's one other option if patient can't take fluticasone.
Where does Antrantil fit into this chart?
Antrantil, so essentially that falls into the, when I say here antibiotics here, so you can use herbal antibiotics. You can replace the synthetic antibiotic with herbal antibiotics, and you can just put it in there. So now you want to use Antrantil, you want to try neem, you want to try oil of oregano, allicin, so berberine, so that falls in that category.
Are there limits to the amount of time you can take Antrantil, or can you take it forever?
Not aware of any time of that. Yeah. So the experts are sitting here. That wouldn't be me. So anybody has any comment on that? How long can you continue with Antrantil?
Sometimes I find that some of the chronic patients, we do a heavier dosage of the herbals, and then some patients that continue to recur, we find out that I have found that sometimes just a low dose of an herbal antimicrobial ad infinitum sometimes is just enough to pretty much keep their symptoms at bay, and if it's, so a lower dosage, but I don't think there's any downside to doing it for long term.
So when you're doing the elemental diet, which I've had great success with people, are you using MMC as well?
No. No, I'm just,
MSC promoter. No.
oh, MSC promoter afterwards? Oh, okay, no, I thought during, yeah.
Not
No.
during. but
No, afterwards, I usually, so here's what happens after elemental diet, right? After elemental diet for about a week, patients don't feel good because, you know, it's all of a sudden now their body is regaining that sort of like, okay, what is this old solid food that you're eating? And then symptoms actually gets worsened for the first week. I usually tell them, okay, if you're taking 14 days of it, and the best you're gonna feel good at day 21. So I wait. If at that time I say that, well, you know what, I'm feeling good, and then they call me and say, oh, your symptoms are coming back, and I'm not doing another 14 days, that's the time is that I'm gonna add something to protein.
Instead of the elemental diet, have you used the fasting making diet for SIBO instead?
I haven't used that, so I don't have much experience with that.
We're not even
I'm
getting to the
getting get out of the room sign.
This is the slides. We're trying to have them Q&A. Only missing your whole presentation.
Alright. Oh, so this is the data that actually I wanted to talk to you about. So this is Target 3 trial. This is a study that was done on 2,500 IBS-D patients. So some group of patients underwent breath testing, right? So actually, we looked at multiple determinants of response in Target 3. We looked at type of symptoms, we looked at demographics, we looked at geographic distribution, looked at age, gender. None of them predicted response to Xifaxan except for breath testing. So if you have a negative breath test, your response rate is 26%, right? So that's kind of answers your question. But remember, 26% is already lower than the usual 35% placebo response in IBS trials. So this is even lower than the placebo response, right? But if you have a positive baseline breath test, then your response rate is 56%. I mean, this is the highest rate you can see in any randomized controlled trial in response to IBS. And then, if you have a positive breath test and the breath test becomes normal, then your response rate becomes 76%, right? So clearly, Xifaxan in the ones who work has got something to do with the small bowel microbiome, in my opinion, based on the results of this study. Alrighty, what else breath testing can tell you? Actually, it can tell you how bacteria behave as opposed to other tests that are available. I mean, hydrogen-producing bacteria are like fast animals, I don't know, or a Ferrari. You just put gas in it and it runs fast, right? And then it runs out of gas and it stops producing hydrogen. That's why when you fast patients, usually the hydrogen is low. But methane-producing archaea are like trucks, they go forever. So they completely act differently, and that's why we have different cutoffs for hydrogen and methane. That's why we don't, some of the breath tests you will see that you add number of hydrogen and methane on top. That doesn't make sense at all, because these are like different living organisms. So we can add on top the numbers. And this was a large study. This we checked in 5,894 patients that this pattern that shows up. So that's the beauty of breath testing and what you can get out of it. So you can move on.
Quick question, what was LBT on the slide before?
Oh, lactulose breath test.
Okay.
Sorry. Right. Yeah. Okay. Another thing is like things that we just doing breath testing and analyzing data, and this is data on 12,000 patients that we found. If you can click one, you can see that this is the percentage of methane positivity as we age. So it starts with around like 7%. It reaches about 25% when like 80s and 90s, and then 40% when 95, which is fascinating. That just tells you the microbiome is dynamic. It's as we age, the whole microbiome is changing, and that will make actually defining what's normal very hard, because it's clearly changing. Now another are sort of like obviously eccentric conclusion of this would be the fact that maybe methane-producing bacteria have got something to do with longevity because people who have methane don't die. Maybe that's it.
Methane produces
Well, obviously that's definitely an eccentric conclusion, but definitely thought-provoking though. All right. Okay. So can I say this or? So this is actually a very interesting case. I'm just going to walk you through it. Fascinating. So 21-year-old girl with refractory C. diff colitis that multiple antibiotics, patient didn't respond. Finally, she got the fecal transplantation in 2014, and after C. diff got eradicated, right? We know that it has 80 to 90% success rate. Fantastic, right? But then she developed severe distension, fatigue, and constipation. Can you quit once? Alrighty, we worked her up, we tried multiple different things, and this was before me, and patient did not respond. Multiple pro-motility drugs and laxatives that did not help her. This is to the point, at this point, she was like, okay, can you give my C. diff back? I'm tired of this, I can't live like this. It's almost suicidal. So, and she was found to have methane-predominant bacterial overgrowth, and then even though a patient has history of C. diff, we just bit the bullet and said that, okay, let's give the patient sort of antibiotics, and symptoms improve. But this is the most important thing. So we went back and looked at sort of the FMT donor, and FMT donor was methane producing. So it's fascinating, you can even transplant archaea these days. So if in case anybody is interested, so that's the, and as you can see, as we learn about microbiome, these even complications of transplantation of microbiome are showing up.
And when you have microbiome banks, right? They're probably not looking for methane producers, right?
Interestingly, after we published this and another study that came afterwards, and now they're checking most of the biobanks, they check their donors for SIBO. Yeah, so to make sure that they're not giving it. All right, so so this is another study that patients who get transplanted from the donor that has positive lactose intolerance after the FMT, they have a lot of GI symptoms, 50% versus 40%. All right.
Question, could it be that some people can handle the methane and don't respond versus another person?
Totally, it can be. That's because some people are walking around with a lot of methane and they have no symptoms.
Right.
Yeah. So now, what determines the response? We don't know. So that needs to be clear for sure. Yes. All right. So I'm at the hydrogen sulfide. So you want to continue or?
Yeah.
Okay. So let's continue.
Wait, she's different.
So. Alright, so if you go back, sometimes we see this pattern of breath testing that we were sort of confused about. Okay, what's going on here, right? There is no hydrogen, there is no methane. Like that's impossible. You have to have some sort of bacteria, right? So it turned out that there is a hydrogenotrophic bacteria sitting in there. So what does hydrogenotrophic means? That it's a bacteria that loves hydrogen. It sucks out all the hydrogen that is being produced. So then you don't have any hydrogen rise, right? And on top of it, methane-producing archaea are left with no hydrogen to produce methane because the other guys stole it all, right? Now your methane is low as well. So this is surrogate for overgrowth of hydrogenotrophic bacteria. For example, one group of them being hydrogen sulfide producing bacteria, right? So if you move on.
Does that cause problems?
Yes, that's, well, actually that would be the next one. Can you go to the next slide? Right.
However you want to spend your time, we just have 10 minutes for like everything. So you can do slides, or we can do Q&A, but like, The library people are telling me that.
No.
Yeah.
We talked about hydrogen sulfide already, right? So this is the new device with the hydrogen sulfide. We talked about it. Alright, yeah, so I guess we can just stop here. So it's just...
But that was a good point. IBD, you can see SIBO.
Can you go back one slide?
You
Yeah, go back to
Oh, okay. You're not stopping. Go back then. Alright, okay. Yeah, go back, another one. Another one. Alright. Go forward now. So just a point about hydrogen sulfide. So it correlates with the patient's symptoms in terms of diarrhea and urgency. And it competes with the methane-producing bacteria. If you go to the next slide. And this is actually interesting because we broke down the data on our IBD patients, and this has been published as well, and we presented it at ACG. There is definitely two things happens in IBD patients. There's more hydrogen sulfide in IBD patients, and this, interesting enough, was a hot topic in the early 90s about ulcerative colitis and hydrogen sulfide. And whether it's, in fact, actually is a causative factors in ulcerative colitis. And in fact, they do have more flat lines in this group. So more research is coming in terms of whether the abundance of hydrogen sulfide producing bacteria in IBD patients is a thing. And in fact, whether we can target them to treat IBD patients.
And what do you know about diet and hydrogen sulfide, right? Because the traditional SIBO diets don't tend to work as well for hydrogen sulfide.
That's true, that's true. Yeah. And another thing is that patients with IBD don't produce methane as much, which is, again, a fascinating concept, because there's some studies showing that a little bit of a methane actually is a good thing. It has, methanogens may have anti-inflammatory effects, which is another interesting concept in IBD patients. And the breath test, obviously, because you want to do this, you want to find this small difference in like a deep sequencing, then you have to spend millions of dollars to get to that conclusion. But with breath testing, because it's available, then we can come up with these hypotheses and then now move on and see and check them in further studies. All right, okay. And we talked about this, and the conclusion, essentially, so we talked about the breath testing that can help with diagnosis of bacterial overgrowth. It can help with diagnosis of carbohydrate malabsorption, including fructose intolerance, lactose intolerance, sucrose intolerance. It can help with that. It's an exclusive biomarker of gut microbiome, and also it correlates with symptom profile, right? What type of gas that you produce, and also predicts response to therapy. And also it helps us with temporal dynamism of microbiome. You saw that methanogens increase with age. And also it gives you an idea about the metabolic behavior of the bacteria. So it gives us a wealth of information that very few tests in medicine, honestly, can give you this much information. As long as you know how to interpret the data. So that's the helpful part. All right.
So I just commend you on your presentation.
Yeah.
One other question, has anyone ever looked at the level of vagal nerve activity in relationship to SIBO? Let's just take it into another one.
Yeah, so definitely that's a hot issue. The problem is that there are a couple of tests in the clinic that we have that we check for vagal activity. Number one is a pancreatic sham feeding test, which is actually physiologically it's a fascinating test. So so you come in, you chew your food, and we check the pancreatic polypeptide, which is an enzyme produced by your pancreas, right? And if you chew it, but you spit the food out, right? You don't eat it. And then we measure the pancreatic enzymes in your blood sequentially. If it rises by 50%, that means that the cephalic part of swallowing that we discussed works, and that is mediated by vagus nerve. If it doesn't go off, that means that vagus nerve is injured. And we find a lot of cases with the vagal nerve injury. Classically, these are patients who have had fund duplication for reflux and the vagus nerve gets injured. Patients with connective tissue disease, the vagus nerve can be damaged. So that's definitely an entity. Now, is there a full study of, like, let's say 200 SIBO patients and see how many of them have a vagal nerve injury? Not yet done.
Is it both vagal nerves or one or the other?
So this one is on both, yeah.
There's two of them on that side.
No, like both of them are the same thing. Yeah.
So what is your outcome with the SIBO? I mean, percentage-wise, what's the cure rate, or is there a cure rate? What's the relapse? Is there a difference between H2 and methane as far as outcome?
So in terms of, everything is different. If you go to a tertiary center, it's lower as opposed to a community center. So the numbers that I'm going to quote is based on studies. So if you look at for example, target 3, which would be the biggest study in IBS patients. So patients, what percentage of patients responded to therapy with the vigorous endpoint of FDA? Actually 44%, right? And out of that 44%, 36% did not have a recurrence within 22 weeks. So you can imagine, so in total, 15% of them, one round was enough and it's not going to come back. So, and the majority of patients will come back. And it's again, that points to the fact that this is not about just fixing just microbiome. You need to fix the underlying motility issue as well. But with methane, is a bit actually lower, unfortunately. The chance of recurrence with methane is higher than hydrogen-producing bacteria. And the data with hydrogen sulfide, we don't have accurate data yet. But based on flatline breath testing, the response rate is similar to hydrogen-producing bacteria.
And is there a correlation between SIBO and positive H. pylori tests?
No.
No correlation?
No.
Wow. Interesting.
Is there any correlation between stress and motility? Looking at sort of, the whole vagus nerve and sensitizing or sympathetic.
Yes, but so whether there is or not, well, obviously there's multiple studies that argue either way. But some studies saying that no, some studies saying that yes. But the big question is that does it affect the motility to the point that it becomes symptomatic? Does it affect the motility to the point that it completely wreaks havoc into the microbiome? I personally don't think so. No. Go ahead.
Sorry, I know you're pressed for time, but a lot of the talk is about the bacteria going back to the ileocecal valve. Some people claim they can massage it closed. Do you have any thoughts on this?
Yeah, so it's really hard to say. So remember, it's a valve, it's not a sphincter. So it's just a connection. So now massaging it truly, can it fix it? So it's hard to say. And studying it and measuring the pressure, it's a little bit tricky, right? There are a couple of studies using smart wheel that go through the valve and try to calculate the pressure gradients of and the pressure profile of IC valve, and that actually hasn't been validated. And in fact, one study actually didn't show any of that validity. So the jury is big time out on the IC valve, whether it functions. But no question that patients who don't have their IC valve, whether it's resected surgically or whatever has happened to it, are more prone to bacterial overgrowth. No question about that. There's no question about importance of IC valve. Whether how to fix IC valve really, if it's abnormal, we don't have solid data yet.
But the main running theory is the cause of SIBO is this bacteria going through and
Yes.
So the whole low stomach acid, all that, as you were talking about.
Well, I mean, yes, so that part is not as clear cut. So we need to sort of learn more about it and see in what situation truly gastric acid is the most important sort of factor. Go ahead.
A choice So why?
Well, I mean, I give them my the whole evidence on, and yes, so there are patients say that no antibiotics, so okay, so then I use the herbal antibiotics.
Your preferences?
My preference is Xifaxan, because I mean, we can't deny the fact that Xifaxan has been tried in Target 1, Target 2, and Target 3. These studies together had close to 5,000 patients. So we have, and that's not just the only disease that Xifaxan has been assessed, right? It has been assessed in hepatic encephalopathies in thousands of patients, and also traveler's diarrhea as well. So we have very good sense in control trials in terms of side effect profile, in terms of drug interactions, in terms of pharmacodynamics of the drug. So we have good data on it. But on the other side, yes, there are situations the patient doesn't want to take Xifaxan or any other antibiotic or allergic to it. Definitely herbal antibiotics, I do use them as well. For sure.
What is your herbal antibiotic?
Again, I'm not the best expert here to talk about those, but I usually use the garlic extract, neem, and berberine. Those are my go-to sort of approaches.
Have you ever used gas or really food on gas?
Yeah, I do use gas, especially on patients who have bloating. So that helps them. I mean, don't expect miracle from it, but definitely in some group of patients, it does help them. That's good.
With a high baseline medication, how do you have
You don't. Yeah, you don't. So that's why we say it's bacterial overgrowth, bacterial bloom. We don't necessarily know where it's coming from. Good question.
Okay, thank you.